Right, so today we tackle questions 11 to 15, and I think these are, in my mind at least, pretty straightforward, except for one which is more how you would manage the situation than it is true knowledge. First things first then, we have an 87-year-old man in question 11. He's fatigued and pale, so giving an a hint that this patient has anemia, which then is confirmed. Hemoglobin is 78 with an MCV 108. So that takes you through your ways of approaching a patient with anemia, deciding whether it is macrocytic, normocytic, microcytic. So this is clearly macrocytic. Platelet count is normal. How would you assess and manage him? Right. So I think the whole thing here is what is the differential diagnosis to a macrocytic anemia, and right on top of all of that is a B12 deficiency. You can almost view it as your model disease for macrocytic anemia is B12 deficiency, and then its differential diagnosis are the other options. In this particular instance, you can understand that the patient would be fatigued with a hemoglobin of 78, but apart from that, vitamin B12 in itself, deficient state, is known to cause fatigue. Right, and the next thing here is that knowing B12 deficiency, because this is probably what this is all going to revolve around. What are the causes? What is the clinical picture apart from anemia? So in other words, what are the neurological manifestations, which you have central nervous and peripheral nervous system manifestations, and then you also have that medical syndrome, the subacute combined called degeneration. The hematological manifestations of B12 deficiency, and lastly, your differential diagnosis list you'll work through for macrocytic anemia. Question 12 is a 36-year-old female that is planning for pregnancy. So you should realize that at the age of 36, this person is getting towards the end of their fertility cycle. Clock is most certainly not in their favor. They have a higher blood pressure, and that is 152/94. You want to confirm these blood pressure readings beyond today's reading. But the BMI in itself is also a clue that this patient is overweight, although not obese, and you would want to check that this patient has other risk factors for hypertension, including, for example, a family history. But you've still to confirm that diagnosis. Diagnosis then is repeat blood pressure measurements weekly for the next 2 weeks, or you can do a 24-hour Holter blood pressure monitor. Right, so patient also does not want to use medications if the blood pressure elevation is confirmed to be hypertension. How would you manage that? The BMI is the clue to the treatment of this. So if the patient is not going to take medications, you want to employ lifestyle changes. So the important headlines there is exercise, weight loss, reduce salt intake. Apart from that is know your other fundamentals of how to counsel patients on lifestyle changes. That is a common theme in medicine questions. Know what the interventions are for lifestyle changes you would recommend. So I would suggest having one page of how you would employ healthy lifestyle changes in the settings of hypertension, diabetes, any cardiovascular high risk scenarios that you are modifying risk beyond just pharmacotherapy. Have one page that you always refer to, and that is your standard answer. Also important to note that if you do decide to go on hypertension treatment in this patient, you are having to choose medications that preferably are safe to use in pregnancy. Then in question 13, you have a 72-year-old male patient with dyspnea on exertion. That's at 200 meters, so they can at least walk a decent distance. They do have orthopnea, and they do have lower limb swelling. All of a sudden, this sounds very much like heart failure. No angina, but the patient does have coronary artery bypass graft done 17 years ago. Patient is on aspirin and rosuvastatin, so they're clearly on secondary cardiovascular prevention. How would you manage him? This is the management of heart failure. So you want to confirm the diagnosis. You go to your basics first: ECG, chest x-ray, bloods, include a BMP. Thereafter reassess, do an echocardiogram, HFrEF, HFpEF, and what medications you are going to give this patient. So it'll be mortality reducing medications, but also decongesting this patient with probably at this point in time oral furosemide. The patient does not need admission. But this is definitely a question around heart failure. So know how to treat acute heart failure, know how to treat chronic heart failure. Be ready to treat the APO scenario, so that is your LMNOP, although we use morphine sparingly. But just know how to treat acute decongestive heart failure as well as the chronic manifestations, preserved and reduced ejection fraction. Good. Question 14. You have an 81-year-old for an elective colonoscopy. Person takes 12 complementary medications, so you can see the list of things there. She asks if they are necessary as she no longer wishes to take them. How would you counsel her? I think the important thing here is evidence-based medicine. So are there any evidence points for any of these? So I think it all pertains, is there a particular indication, and go through each one of them. If there are none, it is safe to discontinue. A number of these are trace elements, and you would be doing levels of them if you are wanting to prove the point that they do no longer serve this person. In all likelihood, this person does probably not need any of them, and you can say that in most instances, if there's no confirmed deficiency, then it is quite safe to discontinue these. There is no evidence in patients who do not have a deficiency that these are of benefit. But you do want to go through the indications for each one. For example, thiamine, you don't want to be discontinuing it if it has been there for a reason, as an example of thiamine potential deficiency in the setting of alcohol misuse, or when you have a patient who's on thiamine with a dilated cardiomyopathy, which is idiopathic, and the patient may be on that for that in case the patient was thiamine deficient, as opposed to, say, for example, vitamin C just as a general well-being thing when there is no scurvy. So that clearly has no role to play. So I'm just giving you the contrast of clear indication, no indication, making sure what is the answer to each one of those. And in general, we know that evidence-based, there is nothing to favor these medications when there is no deficiency. Right, so the last question for today is a 56-year-old male patient makes it into the medicine Viva. I think they've actually landed in the wrong questions section. Nevertheless, we'll aim to endeavor solving this clinical problem. They have a PSA that has gone up from 1.2 to 6.5 in 12 months. He has noted reduced urinary flow over the past 5 years. This person most certainly then has low urinary tract symptoms. How would you investigate and manage him as per urology? Right now, more realistically, this is a concern. You would want to explain to the person what the potential causes are for a prostate specific antigen increase. One, most likely hypertrophy, but it is most certainly not impossible for this to be a prostate carcinoma. On the other hand, you would also want to treat this patient until they are seen by a urologist, so you can provide the patient with both something to inhibit their testosterone pathway as well as give them alpha blockade, so you can use a combination preparation until they have seen the urologist. So I think those are the main things you want to mention. Non-pharmacological therapy, pharmacological therapies, and referrals to urologists. Remember those things I said in the first video that are important in the strategies to answering these questions. So have a good general approach, one that is stylistically easy for you to describe in an elegant oral way. Right, So those are the questions for today. I'll see you tomorrow.